elevate the importance and visibility of the work of this office. Many of the stakeholders I've met with also have great anxiety and concern about their continued representation in the new Office of Health Equity. There will be a new advisory council to the Office of Health Equity with representation from all of those groups. I've also been asked repeatedly, what is the mission and vision and what is the strategic plan for this new office? And that is going to be developed in collaboration with all of the stakeholders. I do not at this time have a strategic plan or vision for this office other than bringing these different programs and offices together to integrate their work. Part of the activity of creating the mission and vision, again, is to get that input, and I'm meeting with the Advisory Council of the Office of Multicultural Services, again, this time in person for several hours on April 9th, and anticipate and look forward to getting their input. As well, we're going to be doing a lot of sharing. The Office of Multicultural Services has a fantastic project that's up and running to reduce health disparities in mental health. And so we're looking forward on the public health side to hear about their work. We're also planning on sharing our work around reducing and eliminating health disparities from the public health perspective. I think there was also a question about level of staffing, and from the Department of Mental Health, there are 4 PYs. Those 4 PYs will be moving into the new Office of Health Equity.
And staff from the Department of Healthcare Services,
So there will be, some of the staff will actually stay in the Director's Office of Healthcare Services and will report to the Medical Director of Healthcare Services, and their work will continue around cultural competency in the clinical services. And we're in constant discussions about healthcare services in terms of how to keep the integration with the cultural competency work. And they've agreed that they'll be reporting regularly to the Advisory Council of the new office.
LAO?
We have no problem with this transition in concept, and I think the only concern would be to make sure that one policy function doesn't dominate the others, but we've reviewed the org chart and the workload and have no issues to raise this time.
And Finance?
No additional comments.
Any questions from committee members? Mr. Monning.
Thank you. I think in concept, the consolidation makes a lot of sense. How do you respond to the concerns of those who feel their mission may be diluted through an integration process?
Again, we want to ensure that the Advisory Council of the office has that level of representation that makes the stakeholders comfortable. We want to ensure that there is a very engaged process with the stakeholders to build the strategic plan for this new office, build the mission and vision moving forward. And, you know, I see a lot of benefit to integrating this work and learning from each other. These offices have been working in separate departments, and I think there's going to be some huge benefit to the sharing of the work, such that public health can give advice to mental health, and mental health to public health and women's health issues as well. And that kind of exchange in this office, I think, is going to bring a benefit to all of the groups.
So one level of integration is at the advisory level, bringing stakeholders who would work directly with you. Do you envision any dedicated staff positions that would continue to have as their primary role these various interest groups? In other words, as opposed to totally integrating all staff functions, would there be under your leadership somebody who would continue to have primary focus on mental health issues, or do you see that all being integrated among everybody?
So initially, staff will be moving with their areas of expertise into the office. The Office of Women's Health, those positions are actually going to be staying in healthcare services. As I mentioned, the cultural competency piece, we do have some vacancies that will exist in that office where some of the women's health staff actually will have the opportunity to fill those vacancies. So initially there will be that specialty that continues with the staffing. You know, I think over time, as folks learn about each other's work, there'll be much more integration of the different offices, but that's going to take some time and some leadership and direction from the stakeholders.
Thank you. And again, I think in the long run, we all gain through the integration and strengthening of seeing the connections between and among these areas. But I think the concern is that transition process. So thank you.
Thank you.
Thank you.
I think what also concerns me, it would be different if a year ago we had talked about this and some planning towards a combined strategic plan had been engaged. So when we had the conversation today, you could say the vision is X, Y, and Z. Mm-hmm. And I say that from having served on one of said advisory committees under the Davis and Schwarzenegger administration, so of having had direct experience serving in one of those advisory committees, and having heard from a number of advocates who have expressed concern, be it perceived or otherwise, about kind of a devaluing of the subject matter when you are reduced from an office that was created by statute to this kind of new combined effort. There's a real concern about the lack of kind of laser focus, particularly when this committee heard a report at the beginning of the season from the California Budget Project. They talked about ongoing and growing health disparities in the women's health area. A couple weeks ago, the Greenlining Institute had released a report on the growing health disparities for communities of color. So at a time when these issues continue to draw headlines as an ongoing issue in California, to have these departments that have for years worked to attempt to address those issues now to be collapsed in a department that does not yet have a strategic plan or a vision, a combined vision, is a bit unsettling. How would you respond?
I was the Solano County Health Officer, Director of Public Health in Solano for 6 years. Mm-hmm. And I helped form the Bay Area Reducing Health Inequities Initiative, BARHI, which represents 11 county health departments, all coming together, dedicated to eliminate health disparities. Mm-hmm. I remember the first report we put out in Solano County in 2004 that highlighted health disparities and all the energy and enthusiasm that created. The reality is that our work over the years, we've seen decreasing rates, as I mentioned earlier, but the disparities continue. Mm-hmm. My feeling is that bringing together these different offices and all their expertise actually has much greater potential than the individual offices alone. Mm-hmm. As I mentioned, they're sparsely staffed with 2 to 4 PYs, with budgets that have been decreasing every year. And by bringing them all together, we're going to have 13 staff in an office dedicated to eliminating health inequities. So I think there's just going to be a lot more potential for eliminating the disparities than there has been in the past.
Mr. Monning, then Mr. Chesborough.
Thank you. I want to thank the chair for her comments and for you sharing the successful history of building multi-county initiatives. Although for me, when I look at health disparities, they're rooted in economic disparities. And there's no task force, there's no integration of services that by itself is going to eliminate or reduce the economic disparities. In other parts of the budget, we're cutting into all kinds of areas of safety net, health services, and protections that are going to take us the other direction, unfortunately. So I'm saying that not with a question or a comment to your department, but just we continue to try to look at solutions kind of in these silos when I think the elephant in the room is there's a direct correlation between zip code and economic status and health disparities and trajectories of disease, illness, etc. So I would hope that part of, as we all move forward together, we keep front and center that understanding of economic disparity being a critical contributor to health disparity and inequities.
If I could reflect on your comment, I mean, you've hit the bullseye. Health disparities is all about what we call the social determinants of health, which is economics, which is education, which is all about where you live. And one of the areas we're bringing into the new office is our health and all policies work, which really begins touching on the social determinants of health. The Health and All Policies Task Force has 19 different departments from a variety of agencies that are looking at all of their policies and beginning to understand the implications for health. So, for example, Caltrans is involved, the Department of Education is involved, CDFA, and a number of departments and agencies beginning to exactly look at what you described.
Mr. Chesborough.
Well, listening to this conversation, a couple of things occurred to me. One is that there's overlapping disparities, and not everybody fits in a silo. Mm-hmm. You know, you can have, immigrant, minority, language problem, woman, gender, right, all overlapping. So that's one thing that would argue for bringing the folks together to try to examine the things in relation to each other and to try to respond to them, not thinking that somehow they're completely unrelated. Mm-hmm. The other thing is, in addition to the economic, and I agree with my colleagues' comments, but it ain't just that one thing. I think language and cultural barriers exist as well, that to the economic, and they're frequently overlapping and interconnected. But mm-hmm. I think there's those additional elements, particularly when I'm most familiar with those things when it comes to mental health. But I think that certainly the same thing would apply to a number of physical health indicators.
Okay. Thank you.
Yes, Mr. Monty.
And just while we're on the subject, I'm encouraged by suggestions that your department and the administration and the agency are considering setting some very public and broad public health objectives. Is that still moving forward? Am I correct in understanding that you'll be using your position and the department and the administration to set some broad public health objectives?
So there are a number of discussions going on in that area. I mean, one that you may be referring to is our department's strategic planning process, and we've engaged with a variety of stakeholders, including the offices I've described, to develop that strategic plan, which will be finalized in the next month or so. And then as well, there's discussions with agency and the governor's office on a variety of the issues.
Right. And all of the above. Thank you.
Sure.
Anything we can do to support you and the administration in using the media access that you all command to get our state moving to eliminate some of these disparities. I would applaud those efforts. Thanks.
Thank you, Mr. Monning. Public comment.
Good afternoon, Chair and members. My name is Sarah Mercer, and I'm with the California Pan-Ethnic Health Network. Excuse my leaning here on the dais. We've been monitoring the proposal, and rather than concerns, I think there are just a couple of issues, and some of them were echoed today as well. I think the first one is around funding, and although the consolidation is also bringing some resources together to look at these issues across different strategies or in many different ways. I think there's also concern that people will get left behind in the process as well, or that some issues may dominate others. And so I think as moving forward, it would be really important to look at how the funding is distributed, or what are the demands in addition to the resources that have been allocated here. The second issue that I wanted to address which was actually addressed here today, is also the issue of bringing together so many different issues: access to healthcare, disparities within access to healthcare, disparities within prevention, mental health, women's health. There are many different issues within there, and then there are also many cross-secting issues. And so I think it's great that there's going to be a strategic visioning process or a re-envisioning about what this office would do to address those issues in a multi-pronged and cross-collaborative way. And then the last part that I wanted to address is also around the issue of accountability. So we recognize that the staff are going to be, or this office will be under the Department of Public Health. However, there may be some challenges or some charges to the Department of Healthcare Services and how the office will be able to maintain accountability both under the Department of Healthcare Services while being housed under the Department of Public Health. Thank you.
Thank you. Next witness.
Hello, Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. We're the only statewide coalition made up of individuals representing underserved racial and ethnic communities, advocating in the area of mental health disparities and cultural competence. And thank you for all your thoughtful questions, because we have the same questions. REMCO does not have an official oppose against the proposal, but the Office of Multicultural Services in the Department of Mental Health is a magnificent office. It is one of those rare exceptions where the community really, really has faith and has worked closely with the Office of Multicultural Services, and they are in charge of a specific program funded by the MHSA, the Mental Health Services Act, which they are a lead in that project, and we're very concerned. Now, the governor's trailer bill language also proposes that $60 million go to the Department of Public Health, if I'm not mistaken, and we're hoping, and again, we actually have no objections. We support that if the people from the Office of Multicultural Services and Mental Health will administer those funds. Because again, you know, we're all for integration, and yes, there should be integration between health and mental health, women and but again, there's this specific project, and we have been following it. We have a stake in it. We actually have a small contract. We want the Office of Multicultural Services staff to continue administering that and being involved, but there's no language and there's no guarantees yet that that's going to happen. So again, everything that the director said sounded good, but you know, we don't have any guarantees. He talked about certain things such as the advisory council, but unfortunately there are no members of the community on the advisory council. The advisory council is made up of primarily county workers and also some people from academia, but not from the community. Although we are meeting with the director on that April 9th meeting. So we look forward to that, and again, we just want to make sure that the Office of Multicultural Services functions are retained, because one of the staff is now going to Department of Healthcare Services. And so, again, it was great to hear that they're going to be talking to each other and going to be, but anyway, thank you.
Thank you very much. Appreciate it. Next witness.
Thank you. Patty Belisama, California National Organization for Women. There's two particular issues that are a great concern for us. One is the language of the bill. Mm-hmm. If women are a central intersectional grouping, then the word woman should be in the mandates throughout the bill. You only see the word woman when you get, or women, when you get to the actual office. Mm-hmm. But the mandates just has race, ethnicity, and LGBT. And standard statutory construction, when you leave something out, it's meant to state exclusion. Mm-hmm. So that's the first thing that needs to get fixed, and that's the biggest concern that we have, because that's an indicator of the intent of the department to have preferences for the different intersections. The other major concern has to do with the the operation of whatever this mysterious strategic plan is going to be. And I don't know anybody in my community that was consulted. So who the 200 stakeholders are, I'd like to know what that list is, because certainly no one from the CCRF community was asked. And there are grave concerns with the definition, because there's hundreds of them, of what cultural competence is. And one being would define a world in which women's reproductive rights would be in grave jeopardy. So if anything, CCRF people and our organizations need to be part of the ongoing conversations. But first of all, fix the language. Thank you.
Thank you. Quick question to the department as the next witness approaches the mic. Were the sitting advisory committees to Office of Multicultural Health and Office of Women's Health involved in your stakeholders' process and communication?
Thank you, Madam Chair. The input that I've received so far is just the beginning discussions about what this might look like. What are your concerns? What do you see as the positives? And so we've not begun a strategic planning process, just to be clear.
Right.
And so I've been going around talking to all of these different groups, including the advisory councils of these different offices and a number of stakeholders around the state, just to see what people think about the concept, to find out what their concerns are.
I just wanted to make sure that the two sitting advisory councils had been a part of some dialogue, at least, about the proposal.
Yes.
Okay, thank you very much. Next witness.
Over here. Good evening, Madam Chair and subcommittee members. My name is Catherine Quinn, and I stand here to voice opposition to this budget proposal. I'm a longtime women's health program administrator and women's health advocate, and as such, I can tell you that this is just a really bad idea for women, because it totally eliminates the Office of Women's Health and Office of Women's Health staff from the Department of Public Health. The mission of the Office of Women's Health is not yet mission accomplished. The Office of Women's Health was created by executive order in '93 and legislation in '94 because there had been a lot of programming implemented without any awareness of or regard for the women's perspective on the design of those programs. And we women, us older women, fought really loud and hard to have the women's voice institutionalized within what was then the Department of Health. Mm-hmm. And so now 18 years have gone by, and we've had some really exciting successes, but it's not mission accomplished. Mm-hmm. And to annihilate and to remove that voice from the Department of Healthcare Services and the Department of Public Health at this juncture in time as we go into healthcare reform is just not wise. Another reason that it's a really bad decision is that the gender lens is needed. There needs to be some sort of a single focus, be it an Office of Women's Health or whatever, to provide the gender lens to all of the programs and all of the deliberations, and the elimination of the Office of Women's Health communicates a devaluation of the women's perspective on the design of their own healthcare programs. We heard that in the national front. Let's not have it repeated in the state of California. Another reason it's a bad idea is the women's
15 seconds. 15 seconds.
Okay, I'll have to move really quick. The women's perspective on health care is not the same thing as assessing health disparities and inequities. And cutting ahead to the most important point is this proposal is misleading. There was reference to the 13 positions. None of those 13 positions are persons from the Office of Women's Health. There's an org chart proposed. The org chart does not reflect inclusion of any women's health focus or initiatives. So I strongly urge the subcommittee members to reject this proposal. It's an extreme policy change that maybe should be heard in policy committee, not hidden inside a budget agenda item. And so please vote no, and thank you.
Thank you very much for your testimony. Next witness.
Good evening. My name is Golshan Yusufzayan. I'm a resident of Sacramento. I'm a member of the California MHC Multicultural Coalition and Alliance of Mental Health Advocates, which is an agency executive providers, educators, and community leaders focused on the integration of cultural and linguistic competence in the public mental health system. The administration's current proposal divides the function and the responsibilities of Office of Multicultural Services between the Department of Healthcare Services and the Department of Public Health, an act that will irreparably compromise the short-term capacity and the long-term efficacy of the Office of Multicultural Services to champion issues of cultural competence and mental health. As a member of the California Mental Health Multicultural, my glasses is bothering me here. As a member of SubCmte, I support keeping the Office of Multicultural Services whole with the Department of Public Health and under the new Office of Health Equity. This arrangement best ensures adequate staffing levels required by the Office of Multicultural Services to carry out its duties in reducing mental health disparities, as well as leverages the achievements of Office of Multicultural Services in creating valuable new partnerships, generating a significant body of data and lessons learned regarding the elimination of racial, ethnic, cultural, and linguistic health disparity, and strengthens the Office of Multicultural Services as a technical assistance provider and health disparity reduction statewide.
10 seconds.
Okay. Established in 1998, the Office of Multicultural Services has provided leadership and direction in the promotion of cultural and linguistic competence within the public mental health system. Additionally, the OMS has worked with community partners to eliminate racial, ethnic, cultural, and language disparities in access, ultimately improving the quality of care within the public mental health system. For the past 13 years, OMS has stood out as an efficient state office by effectively leading statewide initiatives. Also, I'm here with California Network of Mental Health Clients, and we fully support MMC's recommendations regarding OMS. I just want to thank you for your time and opportunity to speak before this matter.
Thank you very much. And if there are members of the public who have written testimony that they'd like to submit to the committee, feel free to give it to the sergeants, and we'll include it in the record. Thank you. Next witness.
Good evening. Shannon Smith Crowley. I'm representing the American Congress of Obstetricians and Gynecologists for California and AAUW California. And I just wanted to highlight something that's a problem where women are omitted. It was just in the paper today. I was surprised to find out that before the last 2 years, female dummies were not used as crash test dummies, and that a very popular minivan went from a 5-star crash rating when they were using male dummies to a 2-star. So that wasn't anybody that was trying to hurt women, it was just omission. That's also what's going on right now under the Affordable Care Act implementation, is we need to keep the focus on including women's health. And 2012 is a critical year, as you know, for putting legislation in place, putting policies in place that make sure that women's health is front and center. An example of omission there is the terrific, I think, in my experience, the California Health Benefit Review Program did a terrific analysis about comparing mandates in current plans to benchmark plans. They didn't use any examples on women's health. Other programs that are being transitioned into the Department of Public Health, such as Every Woman Counts, your next item, one of your next items, the whole program is being shifted over in total. You're not having the personnel changes. So before my organizations could support any change into this office, while it sounds intriguing, we would need to see many more details, have it worked out ahead of time to see how this could work out, and especially given this year and any change to the office this year. while we're doing ACA implementation could really take our eye off the ball, and we can't support this. Thank you.
Thank you very much. Next witness, please.
Good evening. Kirsten Barlow with the California Mental Health Directors Association. We represent the county mental health departments from around the state. We're cautiously supportive of the governor's proposal to transfer the Department of Mental Health Office of Multicultural Services to Department of Public Health. It could, provide the kind of coordination and holistic approach that folks are talking about being the vision, but we do think a high degree of integration would need to happen between Department of Healthcare Services and DPH in this new office, because Prop 63, the Mental Health Services Act, does have a number of requirements in it around reducing disparities. Our Medi-Cal Specialty Mental Health Program and EPSDT also have cultural competency and reducing disparities requirements for counties to follow, so we wouldn't want two state departments coming out and reviewing and creating new requirements related to essentially the same goal. So we'd want to see a lot of integration there. One of the pieces that was mentioned in your agenda is an ongoing reducing disparities project that was established as part of a stakeholder process to reduce disparities in the community mental health system, funded with Prop 63 dollars. We fully support the continuation of that project. However, we do oppose the governor's trailer bill language sort of approach to amending the Mental Health Services Act to, on a one-time basis, take funds from the fund, send them to a state agency for the statewide project. So it's not about the project in and of itself, but the precedent that sets and the signal it sends to voters as well as other elected officials and stakeholders that at any time the legislature or governor could simply amend a ballot measure and appropriate funds for a special project. So we would actually really hope to identify other mechanisms to make sure the project can be ongoing, that the $60 million can go to support the project, but not by amending a ballot measure in this fashion.
Thank you.
Next members, Kathy Mossberg representing the California Family Health Council. We represent the federally funded family planning clinics and obviously have, as they are our clients and patients and those that we serve, have a great focus on women and women's health. And have been a great advocate for the Office of Women's Health over the years, and obviously think before we disband the Office of Women's Health, we do agree with the comments made by members of the committee as well as the chair that we would think this needs to be better thought out. There's obviously, I don't know about how obvious it is, but we don't have a great issue about creating an Office of Health Equity. We understand sort of the creation of this sort of thing, but without a whole plan to come forward and to think that this is just going to be devised, the devil's clearly in the details here, and I think there's a lot of details to be developed. If you look at the org chart, it has been referenced here, that clearly it's not clear to us that there's any room for the Office of Women's Health or personnel that have been there focusing on women's health. And I would agree with the comments made by the representative from ACOG that in light of the idea that we're moving into 2014 and full implementation of the ACA, we really need to be cognizant of that fact before we come forward with this sort of proposal and a change that is not, again, we are not as an organization opposed to the Office of Health Equity, but we do think it needs to be better thought out. And we urge you to reject the proposal. Thank you.
Thank you. Final witness.
Hi, I'm Brianna Pittman with Planned Parenthood Affiliates of California. We also, we're not necessarily opposed to the idea of consolidating, but we do sort of have a lot of the same concerns about sort of how this is done, especially for the Office of Women's Health. I do also think it's important to note that this is coming on off of last year's budget, which defunded the California Commission on the Status of Women. So it was another, entity that was kind of looking out for women and looking at all of, California with women's and a gendered issue, and that's now, no longer in existence. So we would say, however this is done, we do need to continue the work of the Office of Women's Health and their specific focus on women's distinct health needs. So, thank you.
Thank you. Any final questions or comments from the committee members? Seeing none, it's the chair's recommendation that we hold this item open. Okay. Moving on to issue number 8 and our final issue for today's hearing. Transfer of direct services to Department of Health Care Services. Page 35 on the agenda.
That's all of us.
Catherine Camacho again, Center for Family Health. There to my left is Greg Oliva. I knew your name. And the proposal actually splits between our two centers.
Got it.
And then Vanessa Baird from the Department of Healthcare Services, of course, is also with us, as well as our Chief Deputy, Dan Kim. And I have the piece that is affected in the Center for Family Health is the Family Planning Access Care and Treatment Program. That is basically the family planning program that is provides family planning services to those 200% to the federal poverty level and below that are not on Medi-Cal and don't have other insurance. So the questions that the committee asked is to provide an overview of the proposal. And so currently, and if I'm going into too much detail, just stop me. Okay. Currently, the service piece of the Family Pact program is provided and paid for under the Department of Health Services.
Right.
The support staff that actually administer the program is in the Department of Public Health. And what we're proposing to do is we're referring to it as a lift and shift, not changing the program in any manner, lifting the staff that are currently associated with the program, all the funding, all of the contracts, and moving it from public health to healthcare services. And the reason for that is goes into your last question, and I'll get there in a minute, but you asked the reasons about why we were proposing this. For the Family Pact program, that program began in the late 90s, and it was under an 1115 Medicaid waiver. And in 2010, the CMS, the federal government, then allowed us to incorporate it into the Medicaid, the California's Medicaid state plan through a state plan amendment. So it was no longer operating under a waiver, but is in fact part of the Medicaid program. So, and that was done and approved by CMS pursuant to the Affordable Care Act. So when you take a look at the intent of the Affordable Care Act, the fact that this is no longer operating under a waiver but is actually part of the Medicaid plan, then it made perfect sense to us that that program that provided those services should go to the Department of Healthcare Services, where both the support and the local assistance funding would be combined. Now, one of the questions that you asked was to explain the reasons. The reasons are that we felt it was more appropriate given that it's part of the plan. And then you wanted us also to explain how the public health aspects of the program will be preserved. And that was a concern for not only our program and for the center and for, all of us. So what we made sure of is that we are sending over the components of this program that are those public health aspects. They provide the provider training, the outreach, the technical assistance, the monitoring of the outcomes to make sure that the services that are being provided are consistent in what we would expect. We have monthly reports that, we take a look at what those providers are providing, and that all is going to continue. That funding is going with that support piece to the Department of Healthcare Services. It will retain its status as an office. It will report directly to a deputy director, as it currently does, and Vanessa Baird will be the deputy director that the office will report to. So, again, just like our reduction in Title V, this one was very difficult for us because Family Pact has been a part of our program for a long time, and we've become they're part of the family. But when you take a look at the reasons that we felt that it was appropriate to move, we felt it's inevitable that really is where it belongs. And then I will let Greg talk about the other two programs that are shifting.
Thank you. I think a lot of the reasons that Catherine stated are similar rationale as to why Every Woman Counts and the prostate cancer treatment program are moving to the Department of Healthcare Services. It's more within the core mission of the Department of Healthcare Services to deliver these direct services to medically underserved individuals. And this lift and shift is how it's going to take place. So that exact same program is going to move to the Department of Healthcare Services with its staff, its mandates, a lot of the outreach and provider training that's required within the program. All of those aspects are going to move directly to the Department of Healthcare Services. there are aspects of the program that already exist within the Department of Healthcare Services. The provider, the billing, the clinical claims processing takes place within the Department of Healthcare Services for the Every Woman Counts program. So we believe that there's efficiency that exists by moving them to there, and then there's a strong linkage that exists. Right now, we screen underserved and uninsured women, and if we find a positive diagnosis and need treatment, the Department of Healthcare Services provides that treatment. So those two programs will exist now within the Department of Healthcare Services, and that linkage and alliance will be under that one house, so to speak. The prostate cancer treatment program is provided through a contract with UCLA, so the Department of Healthcare Services would be picking up that contract and all of the commensurate components to it. So,
any comments, Ms. Baird?
So I hate to say something that's different than what Catherine Camacho said. She's very sad to lose FPACT. I frankly am very happy that we're getting FPACT. I love that program. But as my colleagues have already stated, there are already some strong connections between those programs and healthcare services and the Medi-Cal program. The Medi-Cal program is huge, but the reason why we have these other programs is because it doesn't fill all of the needs.
Right.
Bringing these programs over and having them become part of our infrastructure, we think further strengthens and solidifies the foundation for healthcare delivery services in California. It also, I believe, positions us well to be able to prepare for healthcare reform for the benefit of the beneficiaries who will either be moving into Medi-Cal or the exchange, for the provider networks that will continue to play critical roles in the delivery of healthcare services, and to also plan for how we're going to deal with the individuals that are not going to be addressed by healthcare reform, which are the undocumented. So for us, it not only strengthens the foundation of what we have, it helps us plan better for the future. So we think that this is a really good move. We look forward to getting all of the staff, the knowledge and experience they bring, and working with the stakeholders of those respective programs to continue to move them in the positive direction in which they have been going.
Thank you. LAO or Finance? Any comments?
We're fine with the transition of these programs in concept.
Great. Finance, who I got in trouble, I'm sorry. No. Okay. Any public comment?
Hi, Brianna Pittman with Planned Parenthood Affiliates of California. And we represent over 100 health centers throughout the state of California who serve, all of which serve FPAC patients. And we're supportive of this move after some conversations with the Department of Public Health. We're glad to see that we're moving the entire FPAC program, including all the components, including the staff, over to DHCS. So our only concerns would be the potential for overtime to lose the current focus on the prevention and public health, which are obviously so key to family planning. So we're looking forward to further conversations with the Department of Healthcare Services and maintaining that in that department. Thank you.
Thank you.
Kathy Mossberg, sorry, keep interrupting. Kathy Mossberg, representing the California Family Health Council, representing again federally funded family planning clinics, and just want to say, sort of play off what Brianna had said there. We have had a number of conversations, and our first initial thoughts on this were not that we were opposed. We just had concerns around losing the public health aspects, and we've been through those conversations, feel very comfortable. We're sad to lose Catherine, and we're excited, Vanessa, to have you. And it's nice to know everyone loves the program. It is a great program, and it's helped us maintain, as we've seen just this week, our low teen pregnancy rate. So it's an incredibly important program and cost effective. So thank you. We're supportive.
Great. Again, my name is Catherine Quinn. Thank you. Everything that Vanessa Baird said made excellent business sense, and can't do anything but support it. The only reason I'm standing up is in the justification on page 36 of your agenda packet. There's a phrase that says that the Department of Healthcare Services has no plans from the outset to make policy changes to any of these programs. And it might be an innocuous phrase. It just caused me concern because we have some history where there were some major policy changes made in Every Woman Counts, and they didn't consult with the stakeholders. And we as stakeholders, we acknowledge the budget shortfall. We just would have cut it differently. and done some work with periodicity and some of the other ways you could have reduced the drain on the clinical pot. So this causes me concern, and I would really like to hear an assurance that when we do come to that point where there's a desire to make policy changes as we transition to affordable health care, that you bring in the stakeholders, because we're pretty sharp at what might work out in the field and what might not work. And we'd like to be involved in that and not just be told about it afterwards. Thank you.
I appreciate you clarifying that at the end, because I thought you were going to say, we need some assurance that you won't make any policy changes. And I was going to say, no such. Thank you for that clarification. Next witness, please.
I've only been really working on Every Woman Counts program in the last couple of years since there was the change that Ms. Quinn was talking about. And Department of Public Health's responsiveness has been spectacular. And it's just going to be big shoes to fill for our Department of Healthcare Services. Thank you.
Thank you, everybody. It's the chair's recommendation that we hold this item open. And with that, we'll adjourn sub 1 hearing. Thanks for sticking out with us so late in the evening. We stand adjourned.